everyone. I'm Kathy Marshall, Assistant Professor of Oncology at Johns Hopkins in Baltimore. Today we have with us Dr. Tanya Dorff, Professor in the Department of Medical Oncology and Therapeutics Research and the Section Chief of Genitourinary Disease Program at City of Hope Cancer Center. And then we also have Dr. Melissa Reimers, Associate Professor of Medicine in the Division of Oncology at Washington University in St. Louis. And today we're going to be talking about acting on actionable mutations and PARP inhibitors in prostate cancer, especially in light of the recent FDA approvals of abiraterone and olaparib, and then in combination, and then enzalutamide and talazoparib in combination. So to start out, when and for whom are you ordering genetic testing, and are you ordering somatic, germline, or both? And are there situations where you're picking and choosing which ones to order?
Yeah, so I can start with that. NCCN guidelines recommends genetic germline testing for all patients with advanced prostate cancer. So anyone who's metastatic, but also high risk localized and unfavorable intermediate risk. Of course, people with a strong family history, regardless of their DMECO risk categorization, would be appropriate candidates for genetic testing on the germline side. In terms of somatic testing, currently most of the therapeutics that we would use on the basis of those results are in the CRPC state. So some of us are doing somatic testing later when we can get a biopsy of a metastasis. And we do know that there are emergent mutations that can happen as the cancer is being treated. So sometimes we're even doing serial testing using liquid biopsy to make sure we don't miss an opportunity for a therapeutic by missing an alteration that's developed. I do think that as these treatments, such as PARP inhibitors, move earlier into the treatment paradigm, we may need to be doing that somatic testing right up front as well. And again, we'll just need to remember to maybe check later with a biopsy of a new med or a liquid biopsy down the road if there wasn't something at the outset, to make sure there hasn't been a treatment emergent mutation.
I agree with that. And I think what I'm doing a little bit in my practice now as well is, as Dr. Dorff said, is I have been tending to get more somatic testing in the metastatic hormone sensitive state as well. I find it is helpful if we know earlier on if there are potentially actionable HR mutations that we can plan now in advance, especially now that we have some more data in the early castration-resistant setting.
And for the patients with BRCA1 and 2 mutations, there are now quite a few options. There's olaparib monotherapy, rucaparib monotherapy, and then the combinations of the PARP inhibitors with the AR targeting agents. How do you consider these for the patients on treatment, and then also for newly diagnosed patients?
So I can start with that one. I think, as we now know, with the combination of olaparib and abiraterone, as well as talazoparib and enzalutamide, that those studies were done in the first-line setting for metastatic castration-resistant disease. I think, and I'd love to hear Dr. Dorff's thoughts as well, I think one of the major challenges with trying to apply those studies in a real-world setting is the fact that many, if not most, of our patients are now receiving AR-targeted agents earlier on in the hormone-sensitive setting or other states. And the vast majority of the patients, so far as I understand the data from those trials, had really not received an AR-targeted agent prior to enrolling on those studies. So I think a big question is how applicable these data are really going to be in the real world to our patients in clinic.
Yeah, I agree. I think the bottom line is that BRCA in particular is such a good predictor for benefit from PARP inhibitors that we want to use them as early as possible. And so now that we have these combinations that are available in first-line CRPC, if we do have patients who have not been exposed to an AR pathway inhibitor, such as Abi or Enza, if they somehow didn't get that up front because of how their disease evolved, I think many of us are really happy to have that option, since we know the AR pathway inhibitors are so powerful, but so are the PARP inhibitors in this particular subset of patients. So we have that option, but I agree with Dr. Reimers that largely we're going to be using monotherapy because most of our patients will be post an AR pathway inhibitor and or chemotherapy. And in that case, it's really about people's comfort levels with the individual PARP inhibitor, but the labels are kind of different. And so we end up maybe, choosing based on what's on label for olaparib versus rucaparib.
And what about for patients with mutations in the other HRR pathway, in the same pathway, but the other HRR mutations?
Dr. Dorff, do you want to start with your thoughts, and then I can also chip in?
I think there's been a lot of question about which of the other HRR alterations are good predictors for benefit from PARP inhibitors. And there's been some confusion as well because different studies included a different list of HRR alterations. So with every new presentation of data, I think we're all hungry to see how do these less common mutations perform. And so, for instance, with the talazoparib and enzalutamide data that were just presented, many of us were interested to see that the CDK12 subset appeared to benefit more, and CHEK2 seemed to benefit less. Now, this may be different than what we've seen in other PARP inhibitor studies, but this was a combination study in a first-line setting, right? So not only are these mutations rare, but the data are coming from different studies with different populations in different settings. So there's a lot to dissect. And we really just need more information. I think ATM remains a bit controversial. And so more data would be really welcome as far as how PARP inhibitors perform in that particular subset. I don't know what your thoughts are, Dr. Reimers.
Yeah, I agree with that. And I also will just highlight, I think one of my big takeaways, as we know, is that the strongest data really does seem to be for benefit in the BRCA1 and 2 populations. I think it's very interesting that the FDA approval for olaparib and abiraterone was actually based on an exploratory analysis from that data, right? And that in contrast, with TALAPRO-2, with enzalutamide and talazoparib, the approval was for the entire HR population, as Dr. Dorff just said. And so I think that we should still take away that the strongest evidence really still is, even based on the subset analysis for enzalutamide and talazoparib in the BRCA1 and 2 population. I think it will be interesting to see how we ourselves and our colleagues frankly choose to apply the data in the real world setting, because there's still a lot of gray, but certainly for talazoparib and enzalutamide, the approval is broader than for abiraterone and olaparib.
Yeah, you're exactly right that because there's that uncertainty and the difference in the labeling, those conversations with patients can be pretty complicated. And we need to be looking not only at the potential benefit, but also the added risk when you add a PARP inhibitor, and really trying our best to do shared informed decision-making. It might seem exciting for a patient that they could have 2 drugs instead of 1, maybe delay the time for their cancer progressing. But so we need to make sure we fill in on the other side, like what are the risks that they're facing by adding this medication?